Hello, everyone. Welcome. We're going to get started. So welcome everyone to Persyst Grand Rounds, an online series of lectures hosted by Persyst, covering topics related to advanced EEG analysis for improving outcomes in both neurocritical care and epilepsy monitoring environments. My name is Marie Terrell, and I am the Director of Product Management with Persyst, here to introduce our speaker and topic for today's Persyst Grand Rounds. Next slide, please. Through our customers, we understand the importance of investing in the EEG community through education, where expertise and knowledge can grow towards the utilization and implementation of EEG and quantitative EEG. The goal of Persyst Grand Rounds is to provide a platform for those with clinical expertise on topics of advanced EEG analysis as a way to connect with a broader community to share their experience and knowledge so that we can all learn and grow together. Each online lecture features an experienced epileptologist or neurophysiologist presenting on a topic of their choice as it relates to EEG monitoring and analysis. You can visit www.persyst.com/grandrounds to keep up to date. Next slide, please. The opinions and viewpoints of each speaker are solely their own and do not represent Persyst or any other commercial entity or commercial interest. Speakers are not required to include Persyst, its software, products, or services. The content presented was not prepared or edited by Persyst. Persyst is not providing any form of compensation. Next slide. Okay, so there will be time for questions after the talk. There is a Q&A section at the bottom of your screen that you can click on and type your questions in there. We will address them at the end. And this is also being recorded, and a recording will be made available to all registrants. So now, without further ado, I would like to introduce you to Dr. Andrés Rodriguez Ruiz. Dr. Rodriguez is Assistant Professor of Neurology at Emory University School of Medicine. He graduated from the Medical School of University of Puerto Rico Medical School. He completed his neurology residency at the State of New York University, SUNY, Downstate Medical Center, Brooklyn, New York, serving as the chief resident in the last year of his training. He then completed a 2-year fellowship in clinical neurophysiology and epilepsy with a focus on EEG, epilepsy, intraoperative monitoring, and ICU EEG at New York Presbyterian Columbia University Irving Medical Center. He is board certified in neurology and epilepsy by the American Board of Psychiatry and Neurology. Dr. Rodriguez serves on several committees with the American Clinical Neurophysiology Society. His research interests span the spectrum of clinical neurophysiology and epilepsy, including medications and devices for research on epilepsy patients and in healthcare informatics with focus on EEG of critically ill patients. And that it's off to you, Dr. Rodriguez. Thank you.
Marie and Persyst for her kind introduction, and we'll get started with the topic at hand. So what I'm going to talk today. Normally, when I give a lecture about quantitative EEG, I talk about a lot of advanced kind of analysis of EEG. But I felt, that one of the things, that we struggle a little bit at least at Emory is that how to convince our colleagues to just kind of see the quantitative EEG as just a normal EEG. So what I thought, I feel like, why don't we just take a step back instead of kind of talking about very advanced topics in quantitative EEG, and we just kind of go to the very basic of how we assess just the regular EEG patterns that we would normally see in normal patients, and that, on some abnormalities. But the idea is, to go really basic to demystify the quantitative EEG as a just pretty graphs to do not make any sense, and kind of get everyone comfortable, because at the end of the day, quantitative EEG is just EEG in a different representation. These are my disclosure. They're not related to this talk, except for Emory does use Persyst as software for patient care. the idea is, the quantitative EEG, and these are all graphs at this point, but is being increasing pretty steadily across the years in the United States, at least, and it's been persistently growing and growing, and the number of studies that we have to do per day is very large. So when we evaluate the EEG, I mean, it's important to know that, that some of these tools, what they help us with is to sort of how to take a lot of information, a lot of data, and kind of sort of compress that information in a more palatable way that we can do sort of advanced analysis of the EEG, but allow us to do it in a more timely constraint, especially when these big medical centers, are we're monitoring a lot of patients across different hospitals, and it's really important to know that if a study takes anywhere an expert between 15 to 40 minutes to read, these tools help us to make these complex studies into a more simpler. And again, they're not a replacement of EEG, but there are tools to enhance our ability to read much more effective. So that's why it is important to how can we use these tools to read the EEG in a way that is faster but also accurate. And that's one of the things that we had to do. And some of the tools quantitative EEG help us tremendously with this. And again, when you take an EEG, really what we're doing is that we're taking a regular EEG that we take one page, but we can take the whole, this whole page of EEG and then it will be one sort of data point in the quantitative EEG analysis. And there's different panels that we use to read the EEG. Some of them are proprietary, like rhythmic spectrograms. We have the regular power analysis. We can have asymmetry, amplitude integrated EEG, and other tools. But important again is how all this information that you can see an EEG that of 24 hours, we can really compress it into sort of one data point, and it helps us in sort of this colorful way to see the same EEG that we will normally look at manually. And that's how it kind of saves us a lot of time, because we can compress a lot of hours of data in one screen when we do this analysis. And some of the indications of when do we use this technology, so we can use it pretty much in the same thing that we use the EEG for, right? So we use it in cardiac arrest for prognosis. We use it for detection of vasospasm in suprarenal hemorrhage. We use it in ischemia detection to monitor sedation, for bear suppression monitoring. And the most common cause to use this technology is for seizure detection. So these are some of the use cases of when do we use this quantitative EEG analysis. And there's different things, again, that you can rely upon when you're analyzing your patients, who can vary which one are going to be used for depending on what the use case that you have in particular. So today we're going to primarily focus on the frequency analysis, but we're going to touch a little bit on the amplitude integrated EEG. But it's important to know that there is analysis of symmetry, rhythmic analysis, and there is a frequency analysis that we can use. So there's different panels that you can use for different cases when you're analyzing the EEG. Now, again, taking back, how do we actually produce these photographs? And I'm not an engineer disclosing, but it's important to sort of have a general idea of how these things are generated. So when you have a raw EEG, which is the first panel on the top, you see that the EEG is really composed of a mix of frequencies who are together in one single tracing. And a lot of the things that we're doing when we're kind of taking this analysis, we're decomposing these signals who have a lot of different frequencies in the individual frequencies that we normally look at EEG, that will be delta, theta, alpha, beta, and gamma. So in one tracing, we normally have all these things together. So the first thing is that we're trying to do is to separate them in the different underlying frequencies that we look at in the normal EEG. And then, the y-axis of these panels are going to show us those that the frequency 0 hertz or the sort of the delta range is going to be at the bottom, and the gamma or beta range is going to be at the top. And these are how like the different frequencies are plotted in these graphs. But the other point is that these graphs also have a quantification of these discharges, which the quantity, the amount of these frequencies, we can see it by the color being in the red colors of the red spectrum being the more quantity that we see of those frequencies, and the blue or black is when you see very little of those frequencies. And then the amount, we measure using typically the fast Fourier transformation, where we measure the area under the curve to be able to tell those quantities of each of these frequencies. And again, this is not by any means any sort of like a detailed engineering explanation of this, but it's just to give you an idea of how these things are produced in the first place. But then, when we're looking at the EEG or the quantitative EEG itself, there are certain things that we're there's different patterns that we are usually looking at. And some of our colleagues in the ACNS and the Harvard group have, characterized this by sort of specific names to help us to sort of look at the different patterns that we can see. These patterns are not very specific for like a particular disease, but it will help us to importantly that you have to first compare how does the quantitative EEG compares in the regular EEG, and then once you see it in the quantitative EEG, it helps us to quantify very quickly how these things look like, and then you can trace, you can follow them over time. With a lot of information compressed again. And these are one example of the basic patterns that we can see. We can see some patterns that we see characterized as flames, where they have an increase in frequency and they go downwards. And these are what we call regular flames because they look similar to each other. These are more irregular flames or choppy flames. We also can have bands where we have a sort of band pattern where this is a broadband monotonous band, and we can have this narrow band monotonous band. And these are other examples of other patterns that we can see on the frequency analysis. We can see in patterns that typically we see in suppressions, and these are stripes because they are sort of alternating patterns of stripes of some of the flame patterns that we showed you before, with sort of absence of activity in between, and that we typically see in the burst suppression patterns. And then when the EEG is completely suppressed, when we see no brain activity, so we only see the sort of that bluish black representation, because there's not a lot of those frequencies that we were as we described before. We can also see artifacts, and these are some of the artifacts that we can see in the EEG and the quantitative form. Some of them they call them more recently characterized as stalagmites or stalactites, and these are kind of similar to the patterns that we see in the caverns. But these are some of the artifacts, and these are not very specific for a particular type of artifact, but it helps us to identify so you start learning this pattern recognition that is the basic principles of following quantitative EEG. So now, how does it look like when you look at a normal EEG on quantitative analysis? So this is a very, very normal EEG, as you can see on the top of the screen, and you can see how this EEG is very clearly, you can see the posterior dominant rhythm is in here, right? That we normally see on the EEG, and that same pattern can be seen as a thick, narrow band in that alpha range of that posterior dominant rhythm that we can see in the quantitative EEG. So again, trying to show you that the normal EEG patterns that we see in a normal patient, you can see the same structures in the quantitative EEG. And when the patient opens his eyes, you can clearly see the same thing, that the alpha goes away, and then when he closes his eyes, it comes back. Similar to what we will look at again in a normal EEG pattern. So these are patterns that we see in sleep, and these are examples of sleep spindles. Again, like these are how the EEG will look like in the sleep spindle patterns. And then this is how you will look like in a patient who is sleeping. You can clearly see how intermittently you see that spindles patterns that we normally will see in the EEG. And then the patient wakes up and the spindle disappears. And then when the patient falls asleep again, you can see how the spindles return. So again, showing you that the normal structures that we see in an EEG are in the quantitative EEG. Because what I want ultimately from this lecture for you to take is that quantitative EEG is really just EEG, and it's a matter of how do you learn how to discern these patterns in a normal patient. These are examples of hyperventilation. That you see this sort of like high amplitude theta or delta activity, and then that you will see how this pattern, which is that will look like that like sort of little mountain that you can see in hyperventilation when the patient was hyperventilating. Again, that you can identify patterns that are we normally just pay attention to the EEG. You can clearly see identified also in the quantitative EEG analysis. Now, but it's not only normal EEG, right? So we don't do this just for us to see spindles and K complexes or anything like that. So the ultimately, we want to also see abnormalities. So some of the abnormalities that we see in patients who have cerebral inactivity, this is very common. Again, when we have complete suppression, this only you can see here clearly only the EKG, not really much of a brain activity. And this is really clearly how you see how it's very blue, because it means that there's not a lot of frequencies of brain activity that you can see. And this is a very good way to monitor suppression in patients. These are examples of a focal seizure. You see like here in the posterior region here on the left, you can see clearly that seizure evolving over the left side. And the EEG shows very similar pattern with this sort of more complex sort of flame and activity that you can see that's how you will find this representation of the seizures in this patient. And the usual way we use this is that we first identify the seizure in the EEG, and we see how you correlate with that seizure on the quantitative analysis. And then, once you identify how one correlates to the other, you can follow subsequently for seizures that occur over time over the course of the study, without needing to really look at the EEG with so carefully, because the quantitative EEG can help you to see those seizures very clearly and when they stop as the treatment is ongoing. This is another example of how you can see seizures, and I'm showing you different examples so you can see different examples of how the seizure looks like on the quantitative EEG. This is a centroparietal seizure, and again, this is how they will look like in the quantitative EEG analysis. This kind of little mountain, more complex, who increase in frequency and go down in frequency, and sometimes they do also in amplitude, but in this particular analysis, we're just analyzing the frequency. And again, these are right hemispheric lobe seizures. These are, again, the flame patterns that I showed you before, and you can clearly see this seizure in each of these little flames who are sort of very similar to each other. And again, you can monitor, you can quantify these seizures very easily, and even like persons who do not know EEG can identify this very clearly and very easily, probably easier than to see the EEG. And these are other examples of more generalized seizure occurring, and this is how you will see this generalized activity. That's little kind of same flame pattern, but more diffuse on the EEG as the seizure occurs. And a patient with status epilepticus, similar to the ones that I showed you before, you can count the seizures and monitor them over time to see how the seizures are evolving over the course of the status epilepticus. So it will help us to guide the treatment, and the teams who are treating can see this in real time and see how the seizures are evolving or not, or stopping. With the caveat that sometimes as you treat the seizures, the resolution of the quantitative EEG is not always great. If you just monitoring left and right hemispheres, you might need to see more sort of like more regional when you have very, very focal seizures. But you can still see how easily it is to monitor the seizures as they are occurring over the course of the patient in the ICU. And so it's not only seizures that you see, you can also see some of the other type of abnormalities that we see in the EEG. So nowadays we usually are paying a lot of attention to rhythmic and periodic patterns. And these rhythmic periodic patterns are important because are patterns who are associated with seizures. So in the case of lateralized rhythmic delta activity, we can see that clearly here. This activity is occurring here, lateral rhythmic delta activity here. And you can see how this band, it's kind of this very monotonous band is also occurring on the quantitative EEG on the left, showing how this rhythmic activity is showing on the quantitative EEG analysis. Again, showing you that it's very important at the very beginning. You can't just take the quantitative EEG sort of blindly and look at without looking at the EEG first. You first always have to correlate with the EEG, and then you can follow that band over the course of the study that you can easily identify once you correlate it with the normal EEG. So other patterns that we normally see on the EEG could be also lateralized periodic discharges. Again, these are important because they're correlated with seizures, and you can clearly see them here as these sort of more of this linear pattern, which look also sort of like a flame, but more thin, and they don't they don't have a lot of that activity, but you can kind of see this kind of jellish pattern, how it is occurring on the left hemisphere, and these you can follow over time to see how if the activity is going away or not going away, or is it going to become seizures or not. And this is a more of that same activity, but instead of lateralized, is a more generalized periodic discharges. And again, you see this kind of sort of 1 hertz generalized periodic discharges who look like in this sort of yellowish, sort of these little bands diffusely that you see over the course of the study. And you can monitor this activity again for the presence or absence as you monitor the patient. Patient like cardiac arrest, this is very important, and other patients who may have these generalized periodic discharges. So those are sort of some of the abnormalities that we commonly see on the EEG. So we study the normal EEG. We study the some of the abnormal patterns that include seizures, that includes periodic and rhythmic patterns. But it's also important to recognize some of the artifacts that we also can see manifested in the quantitative EEG. So some of these artifacts, we have patients with craniotomy, and that we can clearly see as the patient has this increased frequency and higher amplitude over the right hemisphere. Yes, over the right hemisphere here, and you can see the same thing on the quantitative EEG as this sort of like this kind of choppy flames activity that we can see on the right side. And this is how you normally will look like for craniotomy, that is he's increasing the frequencies and amplitude again in the sort of more higher frequency than as compared to the other hemisphere, that you don't see as much of that same activity in those regions. This is an example of some of the masticatory artifact that we can see here, and we can see very clearly the spirit here on the quantitative EEG. This is a little bit hard to see. This is the sort of the cardiac ballistic artifact, which you can also see here, but it is a little bit harder to see this one as compared to the other ones I was showing you before. And this is the way you will see ventilator artifact that you can see here, and you can see about this activity showing periodically on the quantitative EEG analysis. Okay, so we discussed a little bit of one of the aspects that you can study on the quantitative EEG, which is mostly the analysis of frequency. Now, the analysis of amplitude, or the amplitude integrated EEG, is another way you can analyze this will go through a series of filters and other manipulations that you have to do in order to generate this graph. What important is, that you're taking the traditional EEG, you're going through some sort of transformation that the software produces to produce these graphs, and then you do the compressed visualization analysis of these amplitudes of each of those EEG. So again, here we're not studying the frequency that we were discussing before. In this one, we're studying more of the amplitude of the EEG itself. And this is very commonly used in patient in neonates. Is mostly used, it's also used by anesthesia in doing cardiac surgery, and it's very, very sensitive to the study of burst suppression. So, but I wanted to show you also that it's not only to monitor burst suppression, you can also see a seizure. So will be the amplitude integrated EEG here at the bottom, and you can clearly see where it's very sensitive to. You saw that flame that we were studying before on the frequency analysis on the EEG. This is a seizure that is evolving over the posterior regions, and then you can clearly see how this very distinct sort of little mountain that you can see in the amplitude integrated EEG, because there was an inclusion from having no activity here or suppressed activity. Then you had a higher amplitude in sort of there, and then that can see reflected clearly in these very discrete seizures. And again, this is very easy to see, is that you can clearly see this suppression followed by that seizure with the flame, and the amplitude integrated EEG showing very clearly those seizures. So again, showing you that we can really teach anyone how to interpret these things, that because it's very easy to visualize these different abnormalities. This is how you will look at burst suppression. So again, showing you that is very easy to in the frequency analysis, burst suppression will look like as these little bands that alternates between no activity and activity of the brain. You can clearly see these little stripes which show over the course of the study. So you can clearly monitor burst suppression with these analysis. And you can also see that in the amplitude integrated EEG, in the sort of, again, these little sort of tall buildings or Manhattan's kind of type tall building that alternate with periods of no activity. And again, both of them show, both the amplitude integrated EEG and the frequency analysis can both show this activity. So, but it's important, I wanted to show you one more thing, is that sometimes you have to be careful about tools that you use. So if you use this kind of seizure probability blindly, you will be misled that these are seizures, but really they're not. And this is how it's important to correlate the real EEG with the activity that you're seeing in this analysis. So just learning these things by itself, and if you say, well, there is this probability that the seizures are happening, so you have to be careful that this is more of a burst suppression pattern when you look at it, the EEG as compared to the quantitative EEG. But it is important to correlate it with the regular EEG so you don't mislead yourself into that saying that those are seizures. And one of the things, that I want to emphasize, and I've been telling you all along, is that it's very important to recognize that one of the things that this allows, this is a very sort of easy to do, like to read. Anybody can learn, you can teach them how to, because these are patterns who are very distinct, and you can teach a lot of people how to do this. So one of the things that at Emory we're trying to sort of go in with this technology is that how can we teach this to people who are not EEGers, who would allow us to screen for these sort of patterns that then will alert the neurologists that these are occurring, and then that they can be screened properly on the regular EEG. And this is being published by some groups that this is very feasible. And it's important because we can clearly see that we can teach non-neurophysiologists or physicians to learn how to follow this pattern, so they can learn, so we can kind of put people to screen all these studies across the board and help us to sort of to do more with the same sort of tools that we have. So meaning that we can really do a lot more patients by using these tools because they can allow us to be screened by people who are not physicians. Because at some point the physician is going to have to go to sleep, so we can put this other staff, train them in this quantitative EEG analysis, so they can help us to do this. And this is some of the ways that we're kind of doing this by using these kind of multiple panels where we put different sort of patients. We monitor these patients with trained personnel with this across the board, and then when they see these kind of patterns that we consider patterns of concern, then they will alert the EEG so that we can go and take a look at these patterns, and then we can alert the team if it's appropriate. But again, important, similar to what I showed you before, not to just use the tool in the blind side. So you have to use it in a way where we use these things as a help for the neurologist, so we can actually do this study more effectively. We could probably do it faster. We could probably do higher volume studies, but also it will allow us to be very sensitive by having all this screening happening at the same time when we're not watching the monitors. But I teach you a lot of things that are very basic about quantitative EEG. I wanted also to show very briefly something new, or the new things to sort of like these software companies are doing to kind of help us to also treat another patient population which is not in the ICU. So this is sort of people forget that some of the software has these capabilities. So this is one of the software generated reduction of the muscle artifact. And this is not, again, the traditional quantitative EEG analysis that I'm telling you, but some of these tools can also help with other patients. So this is one patient who was having seizures in the epilepsy monitoring unit. We really couldn't, the seizures were very violent. We couldn't really see anything on the regular EEG, which is the panel on the right. But when we employ this sort of like special software who can remove some of this activity of muscle activity, we can kind of clearly see that we can identify the seizure, or at least the beginning of the seizure, using this analysis. So this has other powerful abilities, and again, that we can actually use for a lot of things. We not even just epilepsy monitoring in the ICU, or seizure monitoring in the ICU, but also for monitoring for other reasons on the epilepsy monitoring unit for epilepsy patients. So I wanted to show that as a sort of like a caveat, which is slightly different from what the talk was about, but it's also to show you that, yes, so there is different things. We can use frequency analysis, we can use amplitude integrated EEG to monitor patients, the seizures, burst suppression, different artifact, different normal and abnormal EEGs. But also it can show us how to do other advanced tools like this for the employment of developing to show the seizures themselves behind the muscle that we would normally miss completely on the regular EEG. So these are some of the references, and thank you for the authors for allowing me to borrow some of the images for this talk. And if you guys have any questions, just please let me know.
All right, thank you so much. Wonderful talk. We have a couple questions coming in, and the first two are about timescale. So the first person missed at the beginning, I think, what the time was set to in the quantitative EEG slides that you were showing.
So
and
yeah.
Go ahead.
Yeah, so sorry. So most of the you can really choose whatever time is appropriate for you. At Emory, we normally like to use 2 hours as the time to screen most studies, and we feel that it's probably appropriate with most patients. Different patient population might require other time scales. For instance, if you monitor, let's say, suprarenal hemorrhage, there's an argument to use 6 hours because that's normal time that you want to at least have a change to say there was acute delayed cerebral ischemia. For things like that, I think, but all these software, Persyst included, you can change the time to whatever is appropriate to your patient.
Perfect, thank you. And then related is another question. Gary Hunter says, excellent review. For the LPDs, the time scale looked almost the same between the raw EEG and compressed display. Is there a way to monitor PDs at a more common compression ratio, for example, 1 to 2 hours?
I think so. I think yeah, will be similar. I guess the response that I gave for the previous one. You can really all this software allows you to, and it's very it's just a setting where you change the timeline and you can set it very similar to your raw EEG. But again, the purpose of the software is to compress the data so you can actually screen very fast. So if you put it at the same exact timeline as the EEG, you're losing some of the sort of like the what you're trying to do, which is really to compress it so you can actually review much faster. So I'll say yes, you can manipulate it, you can put it similar to the EEG, but I would probably say that the compression is what we're looking at so we can monitor these patients faster.
Great. And then here's another question about time setting. So I'll just jump to that one. Celia Barreto says, what time setting for vasospasm?
So basis pattern, we like, at least on Emory, to use 6 hours. And the reason for 6 hours is a lot of literature, they argue that you want to see consistent changes for at least 6 hours to be able to to be able to be sure that the changes that you're seeing are consistent. And so you can alert the team, because you don't want necessarily, when you see patients with acute cerebral ischemia, to have like every time there's a little bit of changes, sort of alert the team every single second, because you want sort of consistent changes. So for that, typically we use the timeline of 6 hours.
Perfect. Okay. And then someone asks, is the spectrum analysis available in the NeuroWorks software useful?
Probably, I don't have a lot of experience of using just the one who is built in NeuroWorks itself. I'm assuming, that anything that uses frequency analysis should be very similar in any software. You can do these things, you can take the numbers and put it in MATLAB and look at them. There's a lot of different companies who would integrate these things into their itself in the software. We use in particular Persyst because we find it useful and it's easy and it has a lot of different panels so we can manipulate them and change it. But I don't have a lot of experience just using the NeuroWorks tool itself, because we have a lot more capability with the other tools like Persyst.
Right. Okay. Next question is, when do you use coherence or phase changes in your diagnosis or analysis?
So that is not something that I use a lot. I mean, I will defer this more to the engineer, mindful folks to answer this question, but that's not something that I, at least in clinical practice, I use very much. And perhaps it's something that we should learn all the different panels and be more, but the ones that I show you are the ones where we typically use probably more commonly, I'll say, in the clinical practice.
Okay, great. And then we have another question. Thank you for the comprehensive review. How accurate would Persyst identify seizures with low amplitude activity or short duration?
So those are more challenging, especially, but it all depends on the configuration of the panel that you have. So a lot of what you're trading off is ease of screening and looking at things, and like how easy it is to do, and how comprehensive you want to be in your detection. So a lot of us, what we do is that we use left and right hemisphere in most of these panels to screen all these seizures. Some of the seizures are going to be very, very, very evident. But if the seizures are extremely, extremely focal, using those kind of the big left and right hemisphere panels are going to be less sensitive to the very, very focal seizures. For those, you doing panels who are more regional, or even like kind of sort of left and right temporal, which will be more regional, will be more useful, or even you can do it by sort of even more sort of reduce the region. So those are going to be more sensitive to pick up these kind of subtle seizures. The issue always is like, how many panels you can fit in the screen to be able to see all those things, and how easy would that be to screen those panels with so many different regions of the brain showing at once. So you have to sort of balance. So you can do it, and you would probably be able to see it in the more sort of like constrict panels who have less channels per panel. But those are gonna probably sometimes, not always, but sometimes we'll miss these very, very, very subtle and small seizures because of that. But then you can then turn to this other type of more restricted panels when you're trying to sort of look for those seizures. But again, but I want to emphasize again that the quantitative EEG is not a replacement for EEG. It's more of a tool that will enhance your ability to read the EEG.
Yeah, that's right. It may be worth mentioning, Dr. Rodriguez, I think that your site has not yet upgraded to Persist 14. Is that true?
Correct, yeah.
Yeah, and that's for those still listening, it's a brand new seizure detector. So it's a brand new algorithm, and you can read more about that on the website if you're interested. And Dr. Rodriguez, we of course would be very interested to hear about any experiences that you have with Persist 13 versus Persist 14 in terms of the seizure detector. So yeah, we're looking forward to that. Okay, and it looks like we have a couple more questions. Sonal Bhatia asks if there are any resources on patterns seen in pediatrics.
I think I'm not as familiar because I'm an adult epileptologist, so I'll probably say I will defer to my pediatric colleagues about that. But if you want, I can ask that question and find more information for you later on after the talk.
That's great. And also, I think it's worth mentioning for the Persist Grand Round series, we have had several speakers who are pediatric epileptologists and also work in ICU for pediatrics. And so you can watch those talks on our Persist Grand Rounds page on the website. So I will include that in the response here, but that may be a good resource for you as well. And let's see. Okay, Stephen Chaffee says, great talk, thank you. May I ask, how high is your false alarm rate with seizures, and do your ICU nurses, non-neurophys staff experience alarm fatigue when caring for these patients?
And so that's one of the challenges that we employ. So in our center, we do this a little different. So what we did was that we have trained EEG technologists to read these panels. And the way, so they know both EEG and the quantitative analysis. So in those cases, it's a little bit easier on the physicians because there is going to be not terrible, but there is going to be some amount of false positive result. But in our case, by doing it that way, that the person who's sort of reading the panels also has some knowledge, not as a physician level, but some knowledge of EEG, it helps us tremendously to sort of like remove some of that physician waking up multiple times, because that's one of the concerns. I'll say it's not terrible. The software, especially with the removal of the artifact, is very good at picking up sort of these artifacts. But I would say that it occurs a little bit, and we rely in our center at least by teaching some EEG to the technology, so that way kind of has another barrier to sort of help with that.
Okay, wonderful, thank you. And then what is the percentage of false negatives or positives in seizures in the ICU, for instance, electrographic seizures? So similar.
Yeah, I think, like we said, it's similar response.
Yeah.
I don't have exact number, but it.
Okay. All right. So, and another one, what is the minimal duration of short seizure to appearance in qEEG? I think I've got that question correctly.
I mean, I think if I understood, I'm not sure if I understand the question correctly, but
yeah.
I think what you're trying to ask, like if there's a difference of how long you should consider a seizure or not in quantitative EEG. I want to emphasize that the seizure is a seizure no matter where you see it. And the quantitative EEG is just a representation of the EEG in a different format. So whatever criteria we use to call a seizure in the EEG, which typically nowadays we are very in tune with using the Salzburg criteria for non-convulsive seizures. These are the most common ones that we see in the ICU. Those are going, and the new ICU EEG nomenclature also has a definition clearly of what seizures are. So we'll reference that. Please, that's important to look at the actual definition. So whatever the definition is, which is pattern who more than 3 hertz, who sometimes evolve or not with no evolution, that are at least 10 seconds. That's the typical definition that we consider seizure. That's still the definition that we're going to consider in quantitative EEG. It's just a different way to see the same information.
That's a really great point, Dr. Rodriguez. Yeah, thank you. A seizure is a seizure regardless of how you find it, and the criteria are the same. Okay, here's a good practical question. How long can you read a 24-hour EEG?
So how long does it take to
That's how I interpret the question. Yeah, I think they're asking how long does it take.
So I would say if like I said before, a normal person reading the whole every page of EEG will take anything between 15-20 minutes to 40 minutes if it's very complex. And then but I would probably say you can cut that in more than 3 times or even more than 4 times by using compressed EEG. Because at that point, what you do is that you read the EEG, you have a basic idea of how the EEG and the quantitative EEG will look like, and then you use your quantitative EEG to sort of take more of a sample of EEG reading rather than reading every page of EEG. And that's how you can probably save more than 2 or 3 times the less of time. So we'll say in the 5 to 10 minutes will be more in the realm that you will take you to read a 24-hour EEG if you use it in an effective way. It takes practice to do it. It's not something you will learn immediately, but I think after some practice, you can probably read it pretty fast and even quantify the seizures and see when burst suppression is occurring or not. And so it's really, it speaks up the ability to do much more effective the reading of EEG.
Yeah. Okay. Wonderful. Thank you so much. Those are all the questions that we have for today. And I want to thank you, Dr. Rodriguez. This was a wonderful practical talk, and I think it's really important that we always circle back to basics. So thank you very much for your time today.